Sounds good. Thank you.
All right, so welcome everybody to the University of Colorado Cancer Center Symposium. It is my pleasure and distinct honor today to be able to introduce a close friend and collaborator, Dr. Bradley Corr. Dr. Bradley Corr is an assistant professor in the Department of OB-GYN and is a director of clinical research. Dr. Corr received his Bachelor's of Arts at Middlebury College and his medical degree from Vanderbilt University Medical School. He completed his residency at the University of Pennsylvania and his Gynecologic Oncology Fellowship here at the University of Colorado. An interesting factoid about Brad when reviewing his CV, his Bachelor's of Arts actually is in geology. So kind of a rock person, it sounds. Dr. Corr became faculty in 2017 and has been tremendously successful in addressing both the clinical and the research missions of the Gynecologic Oncology Division. Since becoming faculty, Dr. Corr's interests have been building the gynecologic oncology practice and taking part in running clinical trials for gynecologic oncology. He has been part of an impressive 22 clinical trials as either the local or national principal investigator. And if that wasn't enough for Brad, in 2019, he was awarded the prestigious AGOF-ABOG Award for Early Career Clinical Researchers, which has really supported and protected his effort in the work that he's going to be talking about today, which is targeting beta-catenin mutated endometrial cancer. And with that, I'll turn it over. Thanks, Brad.
Thank you, Ben. That was a nice introduction. I'm just going to remind everyone to mute their lines if you haven't already. I was just getting some feedback on this end, so just so everyone can hear. So that's pretty much who I am. I do a lot of clinical research for the Division of G1 Oncology, and a lot of my interests early on, I was finding that that in order to kind of progress things forward, it wasn't just figuring out which trials needed to happen, but kind of getting that translational work to actually prove why I wanted to do the trials that I wanted to do. And I became interested in the Wnt pathway pretty early on, and saw a real potential in endometrial cancer, and hopefully today can prove that to y'all. So my disclosures, I sit on advisory boards for Merck, Novocure, GSK, and AstraZeneca, and I have research funded by Clovis. There's no conflicts of interest for any products that I'm talking about today, so so shouldn't be an issue. The learning objectives I pointed out were to be able to identify common mutations for risk of recurrence in endometrial cancer, discuss the rationale for Wnt inhibition therapy in endometrial cancer, which is ultimately where we're going with this, and then to apply molecular classification models to endometrial tumors. So I'm not aiming to make you all into clinicians and or clinicians into basic scientists, but really to be able to understand both sides and where we're going with this research. So I'll start off with the basic background of how I got here and how I got interested in it, and then dive into the deeper interests of CTNNB1 in endometrial cancer, go into our translational analysis that we performed here, and then how that's developed into the therapeutic strategies I have to get this into the patient bedside. And then we'll talk a bit about where my future work is going in this and clinical trial. So to dive into the background, I want to express a little bit more about endometrial cancer. So it's the most common gynecological malignancy in the United States and the fourth most common malignancy in women. The reason why I think that this is also important is that it's one of the few cancers that over the past decade, we've actually seen a rise in. We think about how we've been doing so well in curing cancer or increasing our treatments, which we have, but endometrial cancer specifically is on a rise globally, but nationally as well. I'll admit that, as you can see on the right-hand side, a lot of this is in the more aggressive tumor histology, such as serous or clear cell, but we're seeing an uncorrected rise in all endometrial cancer. So this is a bit background of how we historically and modernly even treat endometrial cancer. The patient gets their diagnosis, usually by an endometrial biopsy. They undergo surgery. And then their tumor factors or their uterine factors, classify them into low risk, high intermediate risk, or high risk. And this helps dictate what therapy options the patient should undergo to decrease their risk of recurrence. I think this is a bit dated though. So this really portends on that classic evidence of type 1 versus type 2 endometrial cancer. And I'm really trying to move away from that classification into more of a molecular classification, because I think there's more than just this simple aspect. So here's where I think we really are right now. And this is, I believe strongly, in molecular classification, and to some extent needs to be incorporated into the care of our patients today. So why do I say that to some extent molecular classification needs to be added in? So I think we're in a transition point. And over the past few years, there's been a mentality to meld the two risk stratification models together. And those two are the classic one by uterine factors I've talked about, and then molecular classification. So as an example, let's take a look at a grade 3 deeply invasive endometrial cancer with a POLE mutation. A patient who historically would have received adjuvant therapy, but soon, based on the molecular analysis, we may not need to treat this patient at all. A patient who historically may have gotten a combination of chemotherapy and radiation with significant toxicities. So that ultimately leads us to the question is, should we treat based on uterine factors or on mutational status, or should we be on both? I believe we really need to be thinking about them separately. And I believe that we have excellent current data that shows increased and decreased risks of these classification models. However, I don't think that all of the treatment data is there currently. And that's why I think we still meld the two, but we are moving in that direction towards a molecular-based analysis of endometrial cancer. So this is where it really started, in my opinion. This is back in 2013, which sounds scary, but it's a little historical at this time, is that the Cancer Genome Atlas evaluated endometrial cancer tumors. There were 373 patients and had tumor and germline DNA analysis with a median follow-up of 32 months. They performed whole genome sequencing and RNA-seq data, and were able to identify 4 clusters. And they were able to find the genomic associations and then correlate them with patient outcomes. So I'll talk a bit about the 4 clusters, but what you can see here is that they, on a Kaplan-Meier curve, were able to put these clusters into different risk for progression-free survival. And ultimately, the main categorization was based on somatic copy number alterations along with mutational status. And so the first cluster is the POLE, or the ultra mutated. These are a catalytic subunit of DNA involved in nuclear DNA replication and repair. Initially, they identified 2 hotspots, P286A and V411L. And since then, there's been 3 more hotspots identified. And what's important about this subgroup is that they have excellent prognosis. So you can see here down in the Kaplan-Meier curve, and this has been shown in multiple studies, is that POLE mutation really does portray an excellent outcome. And so there are a number of clinical trials that are developing or currently enrolling that utilize this and actually randomize into no treatment with this mutation. Then there's the MSI, or the mismatch repair deficient group. And so these are the hypermutated groups. There's a larger number of copy number alterations in this group. And there's a correlation with mismatch repair genes, MLH1, MSH2, PMS2, and MSH6. And there's a strong correlation with microsatellite instability and loss of any of the mismatch repair genes. And so we typically use the IHC of MMR to identify microsatellite instability. This is important because there is an approved therapy. Since this came out, the use of immunotherapy is approved in the microsatellite high or mismatch repair deficient tumors with great efficacy. Third, there's the copy number low group, or sometimes they call this no specific mutation present. And I don't actually agree with that one, so I typically call it the copy number low group. It has a low mutation burden. There's few copy number alterations. The tumors are predominantly endometrioid histology, and there's a strong prevalence of CTNNB1 mutation in this group. And that's why I say that I don't really like the NSMP classification. And then lastly, there's the copy number high. And these are also have a low mutation burden, but many copy number alterations. It's classically associated with a TP53 mutation. And these are classically the serous uterine tumors. And so, as you can imagine, we can't really do whole genome sequencing on all of our endometrial cancer patients in a really timely fashion or financial fashion. And so this is how the TCGA analyzed these and came into the 4 subgroups. Since that time, we've developed a more realistic approach to how we develop this. And so these are through the use of IHC and Sanger analysis. So we use IHC to identify the mismatch repair deficient tumors. We use Sanger analysis to identify the POL-E, and then we can use IHC for P53 into this side, which is the P53 aberrant, and then the kind of catch-all is the copy number low group with the P53 wild type. This has been proven to be effective, and we utilize this here. So that's something important to point out, is that this isn't just future science work in genomic evaluation. We actually do this here currently. Starting in this past December, we actually do a molecular classification of all our endometrial cancers up front. And this is the panel that we do, and this is an example of how it reports out. We go beyond the classical NCCN recommendations, and we incorporate a full genomic profile. And this is important because already in the few months that we've been doing this, the information helps us delineate better care for our patients and certain therapeutic models. So I will also say that we have moved beyond the TCGA. So I've listed here a handful of genomic and proteomic considerations in endometrial cancer and the risk of recurrence. These each have significant correlation to endometrial cancer, and I can give an entire lecture series on each of these, but I'm going to predominantly talk about my interest in CTNNB1. So we've spent decades, and many people on the meeting today know that these relationships and pathways, we like to delineate them and put them in straight lines and say this affects this, and therefore if we block this, it should be able to prevent that, etc. But we know that this is what the communication actually looks like, right? There's a lot of crosstalk, there's a lot of blurred lines, and so that portends to why certain clinical models work or don't work. So I've listed here, as I said, some of the things beyond the TCGA classification. But the great thing about where we are in endometrial cancer now is that we've got therapies for almost all of these. And there is a strong push for clinical trials with molecular classifications in endometrial cancer now. And there are a lot of trials coming out, and we partake in them. So let's dive into my big interest of CTNNB1 in endometrial cancer. So CTNNB1 is an oncogene that codes for the beta-catenin protein, which promotes cellular proliferation and carcinogenesis. Mutations in CTNNB1 have been found to be associated with a number of cancers, including colorectal, breast, ovary, lung, and now endometrial. The CTNNB1 mutation seen in endometrial cancer don't have a clear prevalence, but they're cited in the literature between 19 and 52%. It really depends on what cohort you're looking at. What we do know is that these mutations are all predominantly on exon 3. Greater than 95% of the mutations seen are located on exon 3, which is helpful for analysis. So at baseline, beta-catenin is broken down or degraded by a destruction complex in order to regulate cellular proliferation. When this pathway becomes intrinsically activated by the CTNNB1 mutation, the destruction complex is broken down so that beta-catenin levels rise in the cytoplasm and the nucleus and promote DNA transcription and cellular proliferation. So we like to think of translational work, or I've historically thought of translational work as the kind of bench to bedside, but this story took a bit of a wrong turn, and I actually dove into it from the clinical side first, and that's where I really gained a lot of my interest in this. And there are a multitude of single institution or small cohorts looking at CTNNB1 in endometrial cancer, and almost all point towards a worse prognosis. Kernet et al. Published one of the more well-known of these evaluations, and they looked at about 240 endometrial cancers and further evaluated looking at both P53 and CTNNB1 mutations. They found that it was the low-grade, early-stage patients with mutation who were at risk for recurrence. And this here is the Kaplan-Meier curve. So we have recurrence-free survival here and time on the bottom, and wild type versus mutant. You can see here with a relevant p-value that there is a difference in recurrence-free survival in mutated versus non-mutated. And so this patient population is historically one we classify as the low risk of recurrence. So when a patient has a low risk recurrence, we typically quote them at a recurrence risk of between 5 and 10%. And these patients don't often get adjuvant therapy after their initial surgery. So this paper uniquely identified that the patients who were most likely to have the CTNNB1 mutation were those low-risk patients. So they were grade 1 or grade 2. They had less than 50% myometrial invasion, no lymphovascular space invasion, and had a lower stage, so a stage 1 or 2 presentation. And this is kind of where I got excited about it, because it's a population that was kind of forgotten. We used to say, well, you're probably cured. There's a low risk of it coming back. But we all have patients who this comes back at. And when endometrial comes back, it often comes back in a non-curable form. So this kind of intrigued me in trying to treat a population who we thought we had cured, but they weren't. And so I find that this is a kind of a prime example of how molecular classification of tumors may be more accurate at recurrence risk prediction, and may warrant people who historically did not get therapy to get therapy. So we took this idea and performed a case control study here. We identified 15 recurrent stage 1, grade 1 endometrioid tumors and performed a 3-to-1 case control based on age, race, and uterine factors. We did an NGS evaluation of all the tumors, and the only 2 molecular markers that demonstrated significant difference in the recurrent versus the non-recurrent were CTNNB1 and the microsatellite instability factors, as you can see by our p-values here. Importantly, we were also the first to identify that these 2 known risk factors appear to be mutually exclusive. So as we see here, these are the recurrent cases. They were roughly equal at 53% and 47% of microsatellite stable versus microsatellite high. But in the microsatellite stable tumors, they were more predominantly to be CTNNB1 mutant versus more predominantly to be wild type in the microsatellite high subgroup. So before diving into a massive preclinical work, we wanted to make sure that we were barking up the right tree. And so we went back to analyze the TCGA as a large database to further look at what we'd found. And there were 55 tumors that were grade 1 tumors with a CTNNB1 mutation. Only 4 of them had recurrences, and all 4 recurrences had CTNNB1 mutation, while roughly half of the non-recurrent tumors were mutated. So there was a difference in progression-free survival, not overall survival, just barely statistically significant. But and it's really hard to interpret this because there were such low numbers of recurrence, which is what we'd expect in, as I mentioned, that this is a generally low-risk group. But it still wasn't that much to be able to make any statements off of. So I also got interested then, if we think it's classically the low risk, what does the high intermediate risk group look like? So the high intermediate risk group is what I like to think of as kind of the gray zone of endometrial cancer. So the classic definition of this group is based on the uterine factors. And so those are a grade 2 or 3 tumor, presence of lymphovascular space invasion, greater than 50% myometrial invasion, and then it subclassifies them based on their age and how old they are and how many of those risk factors, and then that warrants whether people should get adjuvant therapy or not. But nobody to date had specifically looked at this group in relation to CTNNB1. And so my hypothesis is that CTNNB1 may be the leading driver to the increased risk in this group. And others had evaluated this group, but nobody had looked specifically for CTNNB1 in the high intermediate risk population. So we identified 88 cases, and we found a prevalence of about 25% for mutation versus a wild type. And we had a 15% recurrence rate. We demonstrated that there was no difference in the recurrence-free or the overall survival when comparing mutant versus wild type tumors in this. So that was a little bit discrepant than what we had initially found in the low risk group. We did similarly find, though, that they were mutually exclusive or appear to be mutually exclusive from the mismatch repair deficiency. As you can see here, of all the tumors, we had 23 wild type mismatch repair deficient and 2 mutant mismatch repair deficient. And this was the only one that was statistically significantly different. Due to our exclusion criteria, we had no P53 abnormalities, and the rest were pretty evenly dispersed. We did look at an interesting subclass of multiple classifiers, so tumors with multiple mutations. In a larger cohort, this has been shown to be about 3%. We found it to be in about 8% of our population, which is a bit higher. And this is kind of another talk for another day, but that some of these tend to portray higher risks. So POLI typically takes prevalence over P53 and MMR. So patients with these are more likely to act as a POLI mutator rather than the opposite. So one of the other interests I had with such a larger group was that we wanted to see if we can formulate an IHC pattern to better assess this and really make this more of a national or global evaluation without having to do whole genome sequencing or NGS to identify patients or who are at greater risk. And so beta-catenin is classically seen in the membranes of the cells that you can see here. But the idea is that with CTNNB1 mutation is that, as I expressed before, you get a higher percentage in the cytoplasm and then the nucleus. And so ideally, we'd be able to form an IHC to identify mutated patients. So we had 93 samples in that high intermediate risk group who we could utilize IHC analysis for. And you can see here that we found pretty good evaluation with a sensitivity of 87% and 95% negative predictive value. So we weren't the first to do this. The most prevalent paper we have is from Dr. Costigan et al., who published this in 2020, who had a little bit of a smaller sample size, but had a bit of a better sensitivity, but a worse negative predictive value than us, but pretty comparable. I find that the negative predictive value of this is most relevant. So with a negative predictive value of 95%, I would feel very confident utilizing IHC initially, and then only potentially sending this for sequencing confirmation if a positive IHC was found. This would significantly cut down costs on a global or national level and make this feasible on a healthcare model rather than individual academic institutions only. So let's get into the translational analysis that we've performed. I'll point out that what I've shown you already is more of a single institution, small cohorts, adding to the literature and knowledge, but kind of what I said where the deficiencies were that other studies have done and we hadn't. We are actually performing a large database from multiple tumor banks to do a large confirmatory trial to evaluate the things that I've shown you and to look at CTNNB1 prevalence, as well as correlation to low risk and high intermediate risk patients. And I hope it's going to be the sentinel paper of CTNNB1 in endometrial cancer. So moving on to what we've done in the lab, we started looking off again at the TCGNA RNA-seq analysis of all grade 1 endometrial cancer tumors. We identified in that group 43 mutant tumors versus 54 wild type tumors. And then through a KEGG pathway analysis, we showed enrichment in several pathways, including Wnt. And utilizing iterative modeling, we identified certain Wnt pathway genes correlated with recurrence-free survival, as you can see here on the right-hand side. Ultimately, this may be used in the future as gene expression panel or to help identify more specific correlative genes identified for increased risk, but further work is needed here. But we did identify that patients with this pathway had a worse recurrence-free survival compared to pathway low. So bringing back to the Wnt pathway, there's a number of different locations to try and inhibit this pathway. And this gets even more complicated knowing that several of these locations are actually negative feedback loops. So there have been a number of evaluations in other tumor types with agents such as porcupine inhibitors and others. And toxicity has been the major limiting factor in getting this type of therapy to patients. So my work initially was to evaluate the Wnt beta-catenin inhibition in several areas. So we identified wild type and mutant cell lines, and then wanted to attack them in a kind of shotgun approach to evaluate what might be best in endometrial cancer, since little work had been done in our tumor type. And so we looked at 5 different inhibitors that attacked in different locations along the Wnt pathway, with the idea of trying to identify more successful or less successful areas to dive down. So there was no significant cell death in the upstream targeting agents, except in the HEC265 cell line with the pyrapam. So uniformly, you can see here, except for here, that there wasn't much cell death going on. And we have, again, here's our wild type cell lines, and here's our mutated cell lines. And these are our agents that we use, and you can see concordantly where they attack. Now, more significantly, we saw consistent cell death in the downstream transcriptional targeting agents. SMO 4690, which I'll just call the 4690 compound, was clinically more interesting because the company that we were working with had an orally available agent. And then you also notice that the drug was effective in the nanomolar dosing range. So this was a little bit more clinically appealing to us, and we furthered along our work with this compound. So here we analyzed apoptosis with an annexin assay and proliferation via BRDU incorporation. We see that there was significant apoptosis in 3 of our 4 cell lines, so Ishikawa, HEC265, and HEC108, but not in the HEC1Bs. To further examine the role of CTNNB1, we transduced a serine 33 to tyrosine in CTNNB1 mutant into wild type cell lines HEC1B and Ishikawa. We saw increased apoptosis with the 4690 compound in the HEC1B S33Ys versus the HEC1B parent cell line, but not in the Ishikawa transduced cell line versus the parent cell line. So as you can see, we do see apoptosis occur with drug treatment, but not in impressive rates.
What's going on?
So,
not in impressive rates in either wild type or mutated cell lines.
so you know, like dogs.
Sorry, is there a question?
Like pre-enrollment stuff on the same day. We were able to enroll and treat on the same day with the in-house labs, and then we had to wait for the IDEX labs to come in. I'm sorry.
Why?
Sorry, I guess it's not a question. If you can all mute your line. So here, however, there does seem to be a stronger mechanistic effect to proliferation. So using percent BRDU incorporation, we see a steady, statistically significant dose response in all cell lines except the HEC1B S33Ys, which still had significantly less proliferation at higher doses. This data lends to the idea that this drug may work better as a maintenance therapy rather than a monotherapy, or perhaps in combination with a separate therapy. We next analyzed the TCF transcriptional activity with treatment of 4690. In the mutant cell lines, we saw a significant decrease in TCF transcriptional activity with higher doses. So if you remember where this drug works, it works along the transcriptional activity, so we kind of wanted to prove that. One interesting finding that we still haven't quite wrapped our heads around is this initial rise in transcriptional activity in both our cell lines before its eventual sharp drop off and statistical decrease. In the mutant transduced parent cell lines versus parent cell lines, we first saw that the transduced cell lines controls each exhibit increased transcriptional comparatively. So you can see here and here and here and here that, as you'd expect, the transduced cell lines have a higher transcriptional rate. Next, we see that as that transcription is decreased with higher doses, but more significantly in the mutated cell lines. We subsequently performed a blinded in vivo study of subcutaneous injection of control versus 4690 in 2 mutant cell lines and 1 wild type. We found statistically lower tumor volumes in all 3 cell lines. So again, 2 mutants and 1 wild type cell line. In these 2 cell lines, we did not see any variation in rates of apoptosis as evaluated by cleave caspase 3. We did see a decrease in apoptosis with wild type tumors alone, but we didn't see any significant apoptosis throughout. However, similar to the in vitro analysis, we analyzed the proliferation after necropsy and found statistically significant lower rates of Ki67 in the treated tumors versus the controls. Similarly, we analyzed the beta-catenin expression in relation to final tumor volume, and we found an inverse correlation in the 265 and HEC1B cell lines. So to us, this suggests that increased beta-catenin expression conveys a higher sensitivity to treatment with the 4690 compound. So that makes sense. If they're expressing more beta-catenin, this compound is going to be more effective, and that's where that apoptosis may come in. So we also utilize our knowledge gained from the TCGA analysis that identified the relevant genes and found that the CTNNB1 mutant tumors have a significantly lower MKI67 expression compared to wild type. So this data suggests that beta-catenin mutant tumors likely grow slower, and that targeting the beta-catenin transcriptional activity further slows tumor progression via inhibiting proliferation. So how do we take this back to the patient, and what are our therapeutic strategies? When I first started thinking about this, I was looking at combinatory factors because I wanted to move beyond just single agent therapy. First of all, the simple answer was the company was already doing a single agent phase 1 trial. And so to me, combinatory factors were going to be better recepted and probably more effective in getting this to clinical trial. And so these were the strategies I thought about. And I'm going to focus on the chemotherapy aspect. So one of the things to incorporate when moving into the clinical side is that 4690 was not bioavailable. So fortunately, the company was also making a new orally bioavailable form of a similar drug. So this is 8502, which is kind of the next generation of 4690. This is a CDC2-like kinase, so an inhibitor of CLK1 to 4. It works along alternative splicing, and so that controls specific genes to code for multiple proteins. And in this setting, the drug disrupts aberrant alternative splicing to recode oncogenic protein expression, specifically in the downstream Wnt pathway. So as I said, I was going to focus on chemotherapy combination, and I didn't really just pick that out of a hat. And so paclitaxel is the commonly used single agent for recurrent endometrial cancer. Both anthracyclines and taxanes are really the only 2 to have shown response rates greater than 20% as a single agent in the recurrent setting. And these are some of the clinical trials that have been done in the past. We use this commonly in recurrent endometrial cancer with decent efficacy. But there is a rationale to combining Wnt inhibition with taxanes. So this is a great study by Fisher et al., who combined Wnt inhibitors with taxanes. I can't even pronounce these names, so I'm going to call them VANT and EPA. But VANT works by blocking the Wnt canonical signaling, and EPA contains a combination of a portion of the frizzled 8 receptor that contains the extracellular ligand binding domain. And so it's a fusion protein blocks the Wnt signaling by binding and sequestering Wnt protein. So synergy was found with this in multiple tumor types with taxanes. And so they looked at pancreatic, as well as ovarian cancer. And they saw that the combination of these drugs worked better with taxanes. So when the proposed mechanism that they wrote about was that first, that Wnt antagonism potentiates Taxol-mediated mitotic blockade and promoted cell death. As seen here, after taxane treatment, there's an upregulation of beta-catenin expression by IHC. So we further know that beta-catenin plays an essential role in mitotic spindle formation. As a reminder, this is how taxanes work. So they stabilize microtubules in mitosis and proliferate cell death. This, in the interest of time, I'm going to skip over. They just went into the synergy and reliant on timing. We haven't quite dived into that yet because we're still doing our initial experiments to see synergy. But so we moved on to combine with 8502 with paclitaxel. So the first simple steps are where we're getting similar cell death, and we were seeing similar cell death in the nanomolar range with the 8520 compound compared to the 4690 compound. And as expected, we got good cell death with paclitaxel in each of our cell lines. So using the CompuSyn synergy program, we identified that the combination with paclitaxel is synergistic in all three of our cell lines, HEC265, Ishikawa S33Ys, and Ishikawas. And they were more synergistic at higher dosing and more physiological dosing. So these are our combination index graphs. So combination index works by anything less than 1 is considered synergistic, 1 is considered additive, and greater than 1 is antagonistic. And so these were pretty low non-physiological doses to really get some curves. And we can see that from a therapeutic standpoint, there is synergy seen. So our first combination experiment in mice was a success. In coordination with the sponsoring company, we combined 2 doses of the SM compound, 6.25 and 12.5 milligrams. And we found significantly lower tumor volumes in the combinations compared to the controls and Taxol alone. As we've more recently found that the tolerability of this drug is going well in their early phase clinical trial, we're going to be dropping the 6.25 dose and then incorporating the arm to have a SM alone arm as well to better correlate that and demonstrate synergy rather than just additive effect. So other good news from this experiment is that our toxicity was well tolerated. So in our first experiments in this combination, the mice didn't seem to mind it until we killed them. Sorry, a little mouse humor. So their body weights were equivalent. And then interestingly, on a preliminary analysis of blood sampling at necropsy, we found no hematologic, hepatic, or bone as evaluated by alkaline phosphatase toxicities. Bone toxicity has been a big problem in prior Wnt inhibitors in clinical models. And moving on to future work and kind of what we're doing. So obviously, we'll be developing those in our other mouse models and proving synergy. But what we're also going to be doing is creating a clinical trial on a national level with the 8502 compound and Taxol combination. And we're in discussions to bring this with the company and the national consortium to bring this to bedside. The other work that I've done is to look more at other therapeutic avenues. And so I created a pilot of nanostring-based transcriptional analysis looking at 6 mutant versus wild type stage 1, grade 1 tumors. And interestingly, they clustered really, really well, as you can see here, in only a minimal sample size. So this, along with a recent publication that looked at 23 proteogenomic evaluations of endometrial cancers, leads us to believe that it's not just a simple question of are these mutated versus not mutated. There's a lot more to that. With the example that increased beta-catenin is not only in mutated tumors, but it's also in downregulation of the APC related to this destruction complex. So I think it's more than just mutation versus non-mutation. What was interesting about these findings is that the Wnt signaling pathway wasn't the most variant in these 2 mutant versus wild type subgroups. Actually, the PI3K AKT pathway and the angiogenesis pathway were highly discrepant in this initial evaluation. And so that expanded my thought strategies of combinations into adding Wnt with anti-angiogenesis and the PI3K kinase because there are therapeutic drugs out there already in this avenue. And so we'll be evaluating that in the future as well. And then that's everything that I wanted to talk about today. So, this is the lab and everyone and collaborators as well. I really want to thank everyone on this list. All this work is moving forward really at a great pace now, and putting ourselves at the head of Wnt inhibition in endometrial cancer on a national level. And this is a really strong collaborative work, and I really appreciate it. I'm happy to answer any questions. I'm not monitoring the chat too, so.
Go ahead, Mercedes.
Hi, so I have a question. I wonder, because you did some studies with mismatch repair too. So do you know if there is any link with beta-catenin and mismatch repair?
So the only link that we've seen is that they're mutually exclusive. In the first two clinical trials, the case controls trial that we did, and then the high intermediate risk, we found that they were mutually exclusive of each other. And so we know that mismatch repair deficient is an increased risk for recurrence in endometrial cancer, but we found that in at least the low risk population and in the high intermediate risk, they were exclusive of each other as far as risk factors. So there seemed to be less dual crossover or compared to others.
Although, because I think you have an enrichment of wild-type beta-catenin in the mismatch repair, right?
Right.
Yeah. So it's almost like beta-catenin is needed for those in the mismatch repair, maybe an additional survival signal.
Yeah, potentially.
Because it could be like, yes, it's not a mutation, but it could be that you can also interpret like a beta-catenin is critical, maybe in those cases for survival. And that's why you don't see many of the, you basically enrich in the wild type.
Yeah.
It's because, yeah, you see a clearly distinction in that group. I was just curious to see.
Yeah.
Thank you.
Yeah, hi, Brad. Is there any relationship between the steroid receptors and your beta-catenin mutations?
That's along future work. So we're really trying to dive into what these relations are. So one of the first things I looked at was actually the ER and PR, which I know you're highly interested in, and there's a lot of work in relation to those. I found it to be a lot more complex, and so the therapeutic strategies were going to be a lot more difficult. So I dove into the chemotherapy avenue first. So I think, yes, there is a lot of crosstalk there. I've yet to dive into it to any depth yet.
Yeah, sounds good. And the other thing, my other favorite molecule is, of course, PKC delta. And I know that was linked to Wnt beta-catenin signaling and downregulation of APC in colon cancer. Mm-hmm. And as you know, we showed that there were some changes in delta in some of the endometrial cancer subtypes. I'm just wondering if that cropped up on any of your gene expression panels.
Only I think in the, I'm trying to think, not that I recall. The only thing, yeah, not that I recall. Although in the nanostring data, we did see the PI3K correlation with mutant versus not.
Cool.
Okay. If there are no more questions, I relinquish 15 minutes back to everybody to review a grant or something.
Thank you all.
Thank you, Brad.
As a kind reminder, people, trainees are welcome to stay on the call for a while and meet with Dr. Corr.